Welcome back, everybody. David here again with Med School Bootcamp. So to wrap up this chapter, we're going to do a little bit of a summary video where we really break down some of these benign bone tumors. And the next slide, we'll talk about some of the malignant bone tumors. This is really just a general overview video. Won't take too long. If you want detailed looks at all of these individual bone tumors, go ahead and check back at the earlier videos in the chapter. This is really just a summary. The night before your test, the day before your test, whatever it may be. Hey, how do I refresh myself on what these bone tumors are? What are the high-yield things I need to know to get my questions right on test day? Remember, a benign bone tumor is a localized, slow-growing tumor that may or may not need treatment on patients. But when we think about them individually, we really want to focus on a couple key things here, one of which is going to be the epidemiology. We also want to focus on key location, diagnostics, and management. So the first one we're going to talk about is the epidemiology here. And if you remember the video at the beginning of this chapter, we talked about an osteochondroma. We said this is the most common bone tumor overall. It's typically going to be in a 10 to 30-year-old age range. Again, this doesn't mean that a 45-year-old patient cannot have this tumor. But when we think about questions and we think about board-style questions, they're often classic presentations. So where are we most likely to see this patient? Typically, it's most likely to be seen in this age range. So we want to think about this as we're building our differential. In the first line of most boards' questions is a so-and-so year-old patient, 50-year-old, 70-year-old, 10-year-old patient. We want to be thinking about what range are we in? What kind of pathologies are most likely in that patient's age range. And so that's why it's important to keep this in mind. When we think about our location here, we're dealing with the metaphysis. Remember, the metaphysis is kind of that middle portion of the long bone. If you recall from this nice image we have on primary bone tumors, we have the diaphysis, which is the really long portion of the bone, the metaphysis, which is kind of the middle. I remember the M in metaphysis for middle, and the epiphysis is kind of the end portion of the bone. I remember the E in epiphysis for end. So remember, our anatomy is really important. And then where are these particular tumors located? We're talking about the osteochondroma, most likely to be in the metaphysis. From a diagnostics perspective, this tumor is most likely to show up as a sessile or pedunculated lesion. Again, if we draw our attention to our image, we can see this kind of pedunculated bony growth with the cartilaginous cap growing out of the bone itself. Now, when we think about the management here, these patients do not necessarily need surgery. It's only if symptomatic. However, key point for this tumor is about 1% of them can transform into a chondrosarcoma. And if you recall from previous videos in the chapter, a chondrosarcoma is a type of malignant bone tumor that would need more aggressive therapy. So important to keep in mind, osteochondroma is benign in and of itself, but about 1% can actually turn into a malignant form called a chondrosarcoma. Now, if you draw your attention to the next one, we're talking about the enchondroma. This is the most common bone tumor of the hands. If you see a tumor in the hand in kind of this younger to middle age range, you want to be thinking about an enchondroma. This is most likely to be seen in the medullary portion versus the cortical portion of the hand, foot, or femur. Recall, when we talk about bones, the kind of hard portion out here is the cortex, whereas the middle portion, or the spongy bone, is referred to as the medulla. So we're talking about bone tumors now that are more likely to occur in this middle portion of the bone, or the spongy bone. Now, when we think about the diagnostics here, this is going to be a well-defined lucency on imaging. That is to say, it should have a very clear appearance rather than something that's a little bit more sporadic or chaotic that doesn't really have a defined shape. When we think about the management here, again, as with a lot of these benign bone tumors, surgery if symptomatic. If the patient's not having symptoms and it's just found, you might just do a watchful waiting approach. The bone tumor is not causing any systemic symptoms, so there's no reason to be aggressive with our therapy. However, if things change over time, it might require surgical intervention. The next one that we talked about was going to be the osteoma. The osteoma is most likely to occur in middle age. It's often going to be found on facial or cranial bones, which again is kind of unique to some of these other ones that we talked about. When we think about the location, if we see one on the face, this should be a little bit higher up on our differential just because that's one of the areas it's more likely to occur. Diagnostics will often show a hyperdense and a smooth appearance. And again, surgery can be considered if the patient is symptomatic. Now, moving on to our osteoid osteoma, a little bit of a younger age range here, right? We're talking about 5 to 25-year-olds, going to be seen in the metaphysis or diaphysis. And on diagnostics, it's going to have a radiolucent osteoid core. And so what this means is there's a radiolucent core that's going to appear kind of dark on the x-ray. It's then going to be surrounded by sclerosis, which gives the osteoid osteoma this kind of classic appearance. Again, we have actual x-ray and CT images shown on the video in this chapter, so go ahead and check that out as well if you need a little bit more of a refresher. Again, talking about the management here, surgery if symptomatic, but a key point for this one is that these patients respond to NSAIDs or anti-inflammatories. Why is this so important? Question writers love to ask this particular question because it's in contrast to a very similar but different primary bone tumor. And that is the next one we're going to talk about, which is the osteoblastoma. We talk about the age range here again, typically a younger patient. This one's more likely to be seen in the vertebra or the diaphysis. This is going to be a well-demarcated cortical tumor. Again, we talked about the cortex versus the medulla. These patients will also get surgery if symptomatic. However, this bone tumor does not respond to NSAIDs. So this is the key contrast between the osteoblastoma in the osteoid osteoma. If a patient has osteoid osteoma that is causing them pain, they take anti-inflammatories, they report the pain gets better. If a patient has an osteoblastoma and they take anti-inflammatories, they report no changes or minimal improvement in the pain. Again, a key contrasting point that the board writers love to ask you about on test day. And finally, to wrap up our benign bone tumors, we have the giant cell tumor, typically going to be in quite a wide age range, 20 to 40-year-olds on average. Again, a 10-year-old could have this, a 50-year-old could have this, but on average, this is the age range that we're thinking of. This is going to be in the metaphysis and or the epiphysis of the bone. And on imaging, you're going to see an osteolytic multicystic lesion, which can also be called a soap bubble appearance. When we think about the pathology here, we see something unique called giant cells, and this is important because this is called a giant cell tumor, but this is an important histopathologic finding because in this pathology, you get overexpression of rank L expressing cells, which are neoplastic. These lead to the giant cell formation, which if seen on pathology can make this diagnosis much more likely. Now, I want to turn our attention to some of the malignant bone tumors. And so the three primary ones I want you to know that we talked about in this chapter are going to be the osteosarcoma, the chondrosarcoma, and the Ewing sarcoma. We're going to break this up in epidemiology, location, diagnostics. We're going to talk about radiographs and histopathology. It becomes a little bit more important with these malignant bone tumors. We're more likely to get a histopathologic sample because it may change how we treat the tumors compared to some of the benign tumors we might just settle with the imaging itself. And then finally, we'll also talk about the management. So first, let's talk about the osteosarcoma. The epidemiology is going to include a bimodal age distribution, 10 to 30, and then greater than 60. So again, this means there's not a lot of cases early on, then there's a spike in cases in a certain age range. There's not a lot of cases in kind of the middle age, and then there's a spike in the cases as patients get older as well. This is called bimodal, bi meaning two, because there's two primary areas where we'd expect to see, or two primary age ranges we expect to see this pathology. Now, when we think about the location here, typically going to be in the metaphysis or the middle portion of that knee region. Again, if you draw your attention to our primary bone tumors, we have the osteosarcoma, more likely to be in this area right here, which is going to be the metaphysis. Now, when we think about diagnostics, and particularly the radiographs, we're going to see a couple of things, including a sunburst pattern, Codman triangle, and osteolysis. So the idea here is that as the tumor expands and grows, it actually causes the periosteum of the bone to lift up. And if it lifts up from a couple different areas, you can get this triangle type appearance. And so again, as this tumor is growing, the periosteum or the outside of the bone gets elevated with it. And the elevation of that periosteum can kind of create this triangle appearance. Additionally, the sunburst pattern is the idea that you get these fibers that grow out with the tumor. And we talked more about this in detail on the actual video. However, this kind of gives an appearance of the sun bursting or kind of coming over the horizon on X-ray findings. On histopathology, you get these pleomorphic or different shapes and sizes. Osteoid producing cells, these are known as malignant osteoblasts because they're producing too much of it, right? Normally we have osteoclasts and osteoblasts working in tandem to balance out our bone. But if this balance gets out of whack, if we have too much osteoblasts, we're building too much bone, which can lead to this bone tumor. Now, when we talk about the management here, it's going to depend. Is this a primary cause which can respond to surgery or chemotherapy, or is this due to secondary causes? Again, more details on this in the video, but primary osteosarcoma has an unknown etiology, whereas secondary osteosarcoma can be due to a variety of different things, including radiation exposure, Paget disease of the bone, retinoblastoma, bony infarcts, and some other things as well. Now, let's turn our attention to the chondrosarcoma. This is typically going to be in an older patient, greater than 50 years old, often in the medulla of the femur, humerus, pelvis, or ribs. And the radiographic findings are going to include intralesional calcification, sometimes called a popcorn appearance, in addition to osteolysis or the moth-eaten appearance. The histopathology is going to show things like peripheral calcification or hyaline cartilage nodules, which are unique findings to this pathology. The treatment here again is going to be considering surgical excision with or without chemotherapy, and you may consider radiation therapy as well. One key point I want you to compare and contrast here is in the benign bone tumors, a lot of our treatment options were to watch and wait. If they're asymptomatic, they might not need intervention. Notice when we talk about the malignant bone tumors, we're not talking about a watch and wait approach. This is often surgery, chemotherapy, radiation, a much more aggressive therapy for a much more aggressive tumor. And finally, to wrap up this video, we're going to talk about Ewing sarcoma. So Ewing sarcoma is often going to be seen in a younger patient population. Key point here is that this has early metastasis. This needs to be treated aggressively early on in a patient's presentation. When we talk about the location, it's typically going to be in the diaphysis of long bones, particularly the femur, but it can also be seen in flat bones, such as the pelvis. This is also going to have an osteolysis or moth-eaten appearance. This just means that the bone has been consumed in various areas. It's not as sclerotic as it once was, which kind of gives it this mothy-eaten appearance. This is also going to have an onion skin appearance as well. And the onion skin appearance refers to that as the periosteum grows outward from the bone and the tumor grows, it can kind of create this onion skin appearance based on the fiber orientation. On histopathology, we can see the anaplastic small blue cells. Now, important to keep in mind here, we can't confuse this with some other pathologies that would also include small blue cells, such as a lymphoma or potentially chronic osteomyelitis. This is why we have to use the entire patient presentation and not just one individual component when making an official diagnosis. Finally, we're going to talk about the management here. Again, surgical resection with or without chemotherapy, as with a lot of these other malignant tumors. So that's just a general overview of our benign bone tumors and the malignant bone tumors that we talked about in this chapter. There are more to choose from, of course, but these are the most high yield ones that you're most likely to get asked about on test day.